Up next, Stephen Nissen is joined by Dr. Brian Ference, Assistant Professor of Medicine at the Wayne State University School of Medicine in Detroit, Michigan, to discuss a Mendelian randomized controlled trial of long-term reduction in low-density lipoprotein cholesterol beginning early in life.
So what do you mean by a Mendelian randomized controlled trial? I think a lot of our listeners will need some help understanding that.
Well, the trial really invokes the principle of Mendelian randomization, which simply means that alleles are allocated randomly at the time of conception, and polymorphisms that are associated with lower LDL cholesterol, therefore, are analogous to being randomized at birth to a treatment that lowers LDL cholesterol by a small amount, while inheriting the other allele is analogous to being randomly allocated to a control group or to usual care. And comparing the outcomes of cardiovascular disease among persons with and without that polymorphism should provide an unbiased estimate of the clinical benefit of long-term reductions in LDL cholesterol in a manner that's analogous to a randomized trial of comparing a treatment that lowers LDL cholesterol beginning at birth with usual care.
So it's really a simulation of what a randomized trial might actually produce, because what you're doing is you're taking people, the randomization occurs, of course, at the time of conception. So you've got people that have some SNP that will lower their cholesterol, their LDL, by some fixed amount, and you have another group of people who don't have that SNP, and you can then look across long periods of time and find out what the effects are. Is that a...
Right, that's exactly right. What we tried to do was sort of address the notion of residual risk in coronary disease. So multiple randomized trials of statins have demonstrated that lowering LDL cholesterol during middle and later life with a statin reduces the risk of major coronary events. But there still is a fairly substantial residual risk. And because atherosclerosis is a chronic progressive disease that begins early in life, it makes sense intuitively to hypothesize that lowering LDL beginning earlier in life, before the development of atherosclerosis, may actually be somewhat more effective at reducing clinical events than waiting until after a person has already developed atherosclerosis.
And of course, we never get clinical trials in these people because no one's going to start a statin in someone who's a year old and then follow them for the next 50 years. So you looked at 9 different polymorphisms. To what extent were the LDL cholesterol levels lower in people with these SNPs compared to people that didn't have them?
So each of the polymorphisms was associated with a slightly lower LDL cholesterol level that varied between 2.5 milligrams per deciliter and 17 milligrams per deciliter.
That's not so much. That's a lot less than we achieve routinely with statins or other lipid-lowering agents. But you get to follow them for a long time. Now, at the time that you ascertained their outcomes, how old were these people?
Well, they varied according to the study.
Yes.
So they varied in range from age 45 all the way up through the late 70s. Yes. And so the mean age was different for each of the polymorphisms that we looked at.
But typically, these are from middle age to...
into later life.
Later into life. So what you're really looking at is the effect of somewhere between a 2.5 milligram per deciliter and a 17 milligram per deciliter reduction in LDL over 45 to 70 years of time. Is that a fair assessment of that?
These are very much Mendelian randomization studies, but they're meant to simulate randomized trials in sort of a natural randomized controlled trial.
First of all, these are different SNPs. So was the effect different between the different SNPs?
It was. What we found is that there was a different effect for LDL lowering associated with each of the SNPs, but the allele associated with a lower LDL cholesterol was associated with a correspondingly lower risk of coronary disease. However, that risk varied substantially, and there was a significant amount of heterogeneity of effect on the risk of coronary disease among the SNPs. Because our goal really was not to evaluate the effect of any individual polymorphism on the risk of disease, but rather to evaluate with some precision the quantitative magnitude of the clinical benefit of lowering LDL cholesterol over a prolonged period of time, we adjusted each of the associations per unit lower LDL cholesterol. And once we did that, we found a remarkably consistent effect that appeared to be continuous and linear throughout the range of the observed data.
So let's be clear then, no matter how the LDL is lowered, no matter what mechanism of that SNP, you got the same improvement in outcome for every milligram per deciliter or millimole of LDL reduction. So it doesn't matter how you lower LDL, at least by this study.
Right, exactly. So we specifically included polymorphisms, 9 polymorphisms in 6 different genes, each of which lowers LDL by a different mechanism. And once we adjusted the effect of each polymorphism per unit lower LDL, they produced remarkably similar reductions in the risk of cardiovascular disease throughout the whole of one's lifetime. And so what we believe that suggests is that it doesn't matter how improved clinical benefit of lowering LDL beginning early in life is independent of the mechanism by which LDL is lowered, which probably suggests that diet and exercise is a perfectly reasonable strategy to begin to lower LDL cholesterol beginning early in life in the first instance.
All right. So you've got this group of people. They have a 2.5 to 17 milligram per deciliter lower LDL for a long period of time. How much better did they do?
What we found is that, extrapolating the data slightly, for each 10 milligram per deciliter lower LDL cholesterol, there was roughly 20% relative risk reduction. And for each approximately 40 milligrams, or 1 millimole lower lifetime exposure to LDL cholesterol, we found a 55% reduction in LDL cholesterol. We believe this is important because it represents a threefold greater benefit per unit reduction in LDL as compared to treatment with a statin started later in life.
A statin taken for, let's say, 5 years.
Exactly.
So what you're really saying here is that if you lower LDL over a long period of time, essentially beginning at birth, you can get a more than 50% reduction in the risk of developing coronary heart disease.
For each millimole or 40 milligram per liter deciliter. Right. Like the data from the statin trials, the data from these Mendelian randomization studies appear to be linear and continuous. And so one can sort of infer, because of the linear association with the magnitude of LDL reduction during treatment with the statin, the curve wouldn't somehow become lower or alter beyond the observed range of the data.
Let me see if I can interpret that with you. If you went from 100 milligrams per deciliter to 90, you got the same benefit as if you went from 150 to 140. Is that true or not true?
In this study, yes. So, right, the magnitude of the benefit was determined entirely by the magnitude of the LDL reduction.
And that was linear over a broad range as far as you could tell from this study?
Throughout the whole of the range of the observed data.
Yes. And that range, I would think, given the size of these studies, how many people were involved in these studies?
We performed separate meta-analyses for each of the 9 SNPs, both for their association with LDL cholesterol and the risk of coronary disease. And in total, through those 18 meta-analyses, through just the 9 meta-analyses of the risk of coronary disease, there were over 1 million people. However, some of those data were evaluating different polymorphisms in the same population. But because our goal was to measure the quantitative magnitude of the benefit of lowering each unit lower LDL cholesterol over one's lifetime, we combined the non-overlapping data into a mega trial of 325,000 persons.
So big numbers, statistical significance was?
Compared to treatment with a statin started later in life, we found that prolonged exposure to lower LDL beginning early in life was associated with a significantly reduced risk, with a p-value of 8.4 times 10 to the minus 19 per unit lower LDL cholesterol.
That's a pretty small p-value.
Right.
So what do you think the big picture implications are for your findings?
I think that the data show that it apparently is much more effective at preventing coronary events if we begin to lower LDL cholesterol beginning early in life, as opposed to the current practice of lowering LDL cholesterol much later in life after the development of an underlying atherosclerotic burden.
Really does make the case for primary prevention, but of course there's still a lot of argument about how to do that. Do you give drugs? Do you change lifestyle? And you're arguing that it certainly makes the case that lifestyle alterations early in life make a lot of sense.
Yeah, I think what the data suggests is that a renewed and more vigorous focus on promoting healthy diet and exercise beginning throughout the whole of one's life, but particularly early in life, to prevent elevations of LDL is a perfectly reasonable first strategy, and that among those persons who can't maintain ideal levels of LDL cholesterol somewhat later in life, perhaps the middle 20s, it may then be reasonable to contemplate adding on a treatment at that time among persons who are vulnerable to LDL.
Makes a lot of sense. Well, this is a fascinating study, and thank you for bringing our listeners up to speed on the effects of LDL cholesterol lowering really over an entire lifetime. And it's a promising area, and I congratulate you on a fine piece of work.
Great. Thank you very much for inviting me. It was a pleasure.